And now here, I do spine surgery on Wednesdays. I take my kerosene rongeur and I trim off these anterior osteophytes. Okay, so it's a nice tool. Steal it from your spine surgeon, get it nice and dull, and send it back to him. He'll love you for it. But trim those osteophytes. It's very important to do that. Again, once I have my trial in place, I can assess my aneversion. And there I just put a little indicator on perpendicular to the axis of the neck, so I can line it up with the tibia and give me my a sense of how much aneversion I've achieved with my stem placement. And then I go on and prepare my my acetabulum. And through a posterior approach, I just take I do an anterior superior release. I just take a 10 blade and cut my anterior superior capsule. Gives me just enough room to get the neck out of the way anteriorly. No special retractors. I used a Keppler retractor over the front. This is a retractor from Wright Medical. It's held in with a pin. I use a stout Steinman superiorly, and I've got plenty of exposure. And I check there's a cup placement, looking at my abduction and aneversion. And a final placement. And I take an intraoperative x-ray on every case. I've done it since I started practice. Every total hip, every total knee gets intraoperative x-ray. By doing that, guess what? Your x-ray techs get better at doing it. They know that you're going to expect it, and you're not wasting time. They're ready for you. And now that we have digital x-ray in the operating room, it's much faster than in developing a film. This is another series, again, just to illustrate the point that, again, when you're rasping, you want to hang this is a trial going in. You want to hang the conical flare up on the cortical bone, and you'll see that once you've done your rasp, when the T-back will start to engage about 1.5 centimeters before it starts to engage, and you've got about 1.5 centimeters of press fit to drive that in. And again, it's just again illustrating the point that you want that conical flare to engage the cortical bone. I went up to the neck size rasp just to say that there's no way it's going to fit. Okay, it's got too big a flare. You can't really appreciate it here. But I'd crack this calcar if I were to persist with that. And I think you're probably bored with all this. Let's again. Here's what we're looking for with our intraoperative X-ray. Look at limb length, offset, and Shenton's line, and to reproduce the mechanics. There's intraoperative X-ray. Just checking things so you can make adjustments with this modular neck. And in small cases, I've had to bail out. Here's one. It was too small. The neck was too small. I couldn't put a size 1 in there. I could get the rasp in, but the T-back was engaging the cortical bone. If I would have persisted with that, with the trial, I may have cracked it. And certainly the 1 millimeter plus on the implant, I certainly would have overstuffed the proximal neck. So I bailed out and I put in this tapered stem modular device. And again, you can adjust limb length and offset with the modularity of the device to get your limb lengths and offset exactly where you want. I always check stability and range of motion with the trial components in place while they're setting up while they're taking my X-ray. This is an SROM patient on one side. About 10 years later, he came back for his other side. And see that we were a little bit long there. I can make some adjustments. I can cut a little bit of neck off. I can use a varus neck and ultimately get them right where I want them as far as limb length and offset. I want to listen to this. Hear the high pitch? It completely changes the note. And I don't wear I got a bad neck, so I can't wear a bubble over my head so I can hear. And but you got to listen, and you can feel the change in note in the vibration you're getting from the impaction handle. You'll have a lower frequency, and then as you get to a higher frequency, stop. All right. I haven't cracked anything yet. This is the implant, and again, when you put the implant in, you're going to have about 1.5 centimeters of press fit as you drive that in. It's going to go in, and then the last 1.5 centimeters you're going to be tapping that in. Here's a modular neck. You can place it in varus or valgus. You set it's nice that they have a little extractor here, so you can get this thing out. The stem is obviously threaded as well, so you can extract it. Everything you put in, you got to be able to get out. I use a ceramic on poly in this case. Here's my first case. Pretty straightforward, without any problems. Here's a gal that can you see this all? Is it too dark? But she has had dysplasia and destroyed hips bilaterally. I used a tapered stem, and then by the time we did her second hip, we used the arc stem, and she's very happy. She works as a waitress, and there's her bilateral frogs, and you can see you're right down both the diaphyses in both of them. Got a little bit braver. I have some patients that look like the Eiffel Tower. You know, you got two hips, and then you got this spine construct, but she's done very well. Again, restoring her biomechanics. And this is a fellow I did his SROM, young guy, he's a machinist, and ended up doing an arc on the opposite side. So my impressions are that the stem's very stable, that modularity is useful. I like modularity in all my total hip systems. The learning curve was pretty minimal, just pay attention. And I think that doing this through a minimally invasive approach is certainly possible, and my early clinical results are quite promising. So I use it for all comers, you know, A, B, and C bone. It's tough in some of the dimensionally in some of the very small necks and acetabular components, acetabular dimensions. It may serve as a bailout surface replacement. My concerns are it's too early to assess whether we're really going to hold on to that proximal bone in the neck. Impingement is a concern, so small women, I would not use it with less than a 32 millimeter head, and take care of those anterior osteophytes. Be very careful with your acetabular placement, and we may, in some cases, you may want to use a metal on metal or a low profile or a dual mobility type of cup. Thanks very much. And